Good morning, everybody. Happy Thursday. Yes, another VMR. It's gonna be so funny looking back on these someday, and like counting the sheer number of times that we've had the privilege of sharing that and saying that. And yeah, it feels like a privilege every time. And today, I didn't realize the significance of yesterday because we're having back-to-back last names. And yes, back-to-back first initials of the first names, which is a very, very profound source of confusion for even people who know and love Alec, our co-discussant yesterday, and Austin. And before I tell you about Austin, I'll share that I felt really, really bad because was intending to message Alec yesterday and reflect on the case, and instead, guess who I messaged? His beloved twin brother, our discussant today, Austin. Um, and of course, I felt embarrassed, but they are just two wonderful gems and really just revealed to me that their loved ones also mess up. So my level of guilt is markedly diminished. But anyway, today is an all CP Solvers Academy uh, uh, venture, and beginning first with my first discussion with Austin. Austin and I also got to know each other very much like Alec mentioned when Austin was a resident. And it's amazing to reflect on both of them on the fact that both of them are still here. And that's a warning to all of you who are still students or residents. And that warning is that odds are you will probably find another love in medicine. Many of us find so much joy in so many aspects of medicine that there's less and less attendings who are as driven to focus on clinical reasoning as the rest of you are. And so when people make their way through training and still have a strong passion and light for understanding diagnosis and understanding reasoning principles. It's a very, very rare phenomenon, and a phenomenon that makes somebody very, very well fitting for the space. And I think if you know Austin, you know just how passionate he is for clinical reasoning. And those in the VMR Academy chat can literally tell you his reasoning is proportional to his reflections. He is now amongst the CP Solvers team has a reputation for like profoundly deep reflections. And I'm talking like paragraphs of reflections on clinical reasoning cases. It's so cool to see. And it's so cool to have invited him into the CP Solvers Academy mode where he continues to inspire many of us into his pathway. And I know he has an eye towards AI with a recent project proposal. So there's a lot more to come uh, from Austin's career in clinical reasoning, and we're very, very excited to celebrate him today with co-discussion. So I'll pass the mic to you, Austin, to say hi, and then we'll introduce our another Academy member who's presenting a case.
Well, yeah, thank you so much, Robbie. You're always so flattering to everyone. And, it's my absolute privilege to, still be here after this many years. And, I was away for a little while in my previous job and I come back and it's just such a bright spot and such a, really just allows you to sort of, at least for me, re-engage with why I love medicine and why I went into it in the first place. And having this space and this community has just been really, really wonderful for me personally and professionally. So, thank you so much for opening the space. I still can't believe, I'm really just reflecting. I really think we're so lucky that we don't have the like pay for text anymore, because otherwise these poor people, every time I send a text message, just like 5 texts long. They'd be getting like 5 times the charge for every time I send a text. So I apologize to everyone in the chat for that in the first place. But really excited to discuss today and to grow yeah, and hope, and then later today or tomorrow, someone's gonna have to suffer from my reflections from the case today. So I'm disoriented though, Robbie. Where are you? I don't see as many
Yeah,
like
oh,
quick
yeah,
hands
I'm
behind
sorry.
you.
I know. I'm sorry. Occasionally, I have to sit. This is our our guest room. We have some folks over who are out in the main room. I get very distracted very easily, as you know, and so I have hunkered down in our guest room, which I hope many of you will see in the future and come and visit. There have been like 3 or 4 CP Solvers folks who stay in this room, but Reza lays claim that it is the Reza room. So I that's what I'm supposed to say. Um, I just realized actually that we both have had to stand in the might of Parisa's case presentations. I didn't. I've had the pleasure, of course, and I just remembered that you had too, with a very, very complex case of abdominal pain. I'm really, really excited to welcome Parisa. If this is case number 4, is that right, Parisa, or 3?
Three. Number
3.
three.
It feels like 7. Welcome. I'd like to pass the mic for you to say hi, and then we can jump right in.
Thank you, Rabih. It's definitely my pleasure, and I totally agree. It is helping me personally and professionally. And thank you for opportunity to presenting another case to you and Austin as well.
Amazing. Alrighty, I think we got Ashutosh scribing. So yeah, there you go. All right, let's rock and roll.
Thank you. Let's jump into the case. I will present the case in 5 alicot and will pause after each. The first alicot has the chief complaint, which is weakness and back pain in 72-year-old female. I will pause here.
Yeah, Austin, what are you thinking so far? It's an interesting start.
Yeah, no, thanks so much for the start. And I think weakness and back, and back pain are not things that are not uncommon for us to encounter. But I think the combination together is something particularly profound. I see many patients with back pain every day. I see some patients with weakness, but the combination together immediately leads us to step back and say, okay, are these two things together, or are they separate? Because this is, potentially a very, very morbid thing that we have to deal with. So that's a decision or that's a question we're going to be trying to answer right away as soon as we meet with the patient. And to that end, really getting a sense of what the time course is also going to help with that. I think if there's some chronicity to this, it doesn't mean that there isn't a more devastating process going on. But I think the rate at which we have to solve it is going to be decided by how robust these are connected together and how quickly they happen. So I think that's my initial reflection. I think we've talked many times about weakness and what requires you to stand, or at first deciding is this true weakness or is this asthenia. So I probably won't dive into that too much. But I think if we approach the back pain, I often take it from a base rate approach, since I see a lot of back pain in the clinic, and just say, common things being common, this is going to be some sort of non-specific back pain related to the musculoskeletal apparatus. So really our focus whenever we see a patient with back pain is to make sure we're excluding any red flags. And we already have one potentially in the sense of weakness, but really when you're asking the red flags, you're asking for neurological manifestations and you're asking for signs of inflammation. That's really what it breaks down to. Like, are you having fevers? Are you having risk factors for infection, in particular, like endovascular infections? And so really in our first pass, those are the things that I'm going to take in mind. And Rabih, I'd love to hear your approach from there.
I completely agree. I think that's an absolutely superb roadmap to this situation. And I think you'd probably get so much more information by understanding what these things represent by asking the patient how she got to care. And I think I can't emphasize how much it would be so different if this patient had called an ambulance to come to the emergency room versus had come in on her own power. And I think what we're really trying to do, as you articulated, Austin, is to try to establish the nature of the weakness. Is this representative of asthenia, or that the word fatigue is the word weakness is being used to replace the word fatigue, or is it being used to replace neurological weakness? And I think the trap to fall into here is, as we've reviewed before, you're probably going to try to figure out, is this patient just trying to say that she's tired, or is she saying that she's neurologically weak? And I think the trap to fall into, which I fall into in the past, is to assume that it's an or, that you can only be asthenic or you can only be neurologically weak. But this is quite the setup to have an inflammatory disease that causes a sense of fatigue. But that inflammatory disease can be occurring in the back, causing back pain, and consequently also causing neurological compromise, mainly through compression. So I think we have to be very, very careful going forward, not to assume that a patient, especially when they have a red flag for a potential neurological syndrome, namely compressive myelopathy or cauda equina, that they can't have both asthenia, causing a sense of weakness, and then true neurological disease. I'm really curious, Austin, if you were really right there in front of the patient, how do you think the next few minutes would evolve for you if this were reflective of your real life practice? What data would you really try to get in the next few minutes?
Yeah, I think, and this is something I've been reflecting on more is, how much the way that we learn in medical school sort of dictates how we go and interact with the patient. And I think in real time, I don't often get the pleasure of seeing the patient walk into the room, but I think you can make a lot of progress initially by just doing at least an initial physical exam, even as simple as just asking the patient to get up out of the chair if you don't have a sense of what their baseline is, and really focus on more of the basics of the physical exam before I sort of dive into the history. But I think if I'm being authentic to real life, probably what I do is try to understand the time course, try to understand is there signs of inflammation? Try to understand the very basics of the past medical history to make sure that there aren't any red flag signs there, risk factors for infection, immunosuppression, on steroids or things that affect the bones or have a history of bone disease, in particular osteoporosis and so on, that's 72 years old. And then a history of malignancy. Probably those are the things I'd be going through, and then focusing my physical exam from there. But I think if we get a sense from the history that, the back pain is not at least on first pass on a neurological signature, then we're gonna have to step back and really dive into the history more to get a sense of what associated symptoms there are as far as, is this referred pain from the genitourinary tract, for example? Are we worried about some sort of retroperitoneal process going on? And exactly as you said, where is this patient presenting and how did they get there? I'm biased because I'm mainly a primary care doctor, so I'm assuming that this patient's coming to the clinic, but realistically speaking, this patient could have been in the ER, they could be in the hospital. And I think that really helps create a lens about how to approach the patient as well.
Yeah, no, I completely agree with you. I think that's such a wise reflection to give the patient space to think it, to share their story and reflect on that, and to realize that ultimately you're going to have to layer that upon a hypothesis-driven physical exam. And for me, I would just share the real life practical tip that, when you're in training, you're certainly under the evaluatory influence of your evaluators, but when you're independent, you can consider combining the two. And I'm just imagining myself, there's probably a 10% chance that I will be in this situation today when I go to work. And I often find myself, especially when my pretest probability for a neurological compromise is above a certain threshold based on the words and the manner that the patient's using, is I'm examining them and talking to them at the same time. And I can't tell you the therapeutic effect of that. When the therapeutic effect of touch is certainly cultural, and it may not be culturally appropriate where everybody practices, or culturally appropriate based on certain variables in the room, such as the patient's gender, age, so on and so forth. But if you have developing the emotional intelligence to realize that, like, you don't have to be necessarily super meticulous and calculating in your physical exam, and that the patient is giving you the physical space to execute that with some informality, I think that I would probably be leaning in and saying, hey, can you please hold your foot in this? I would probably start like, hey, I'm really worried about your weakness. Let's examine you real quick. And as the patient is doing the neurological exam, and I would probably start with the legs, because if I'm thinking that there's compressive myelopathy, the legs are involved in the vast majority of cases, and the arms less commonly so. And I'm probably like sitting on a stool that's lower down and immediately testing the nervous system, and at the same time getting a history in a sort of conversational way. It requires a lot of experience to have the confidence to do a decent neurological exam and not be distracted by the history and whatnot. So it's definitely something that you can't jump into, but I will encourage you all to realize that in emergent situations, data acquisition can be not necessarily in sequence, but can occur in parallel. We model this all the time in critical care situations where you're getting a whole bunch of data at the same time, but you can do that on a smaller scale in instances like this. Okay, all right, Parisa, tell us more, please.
Never gets old. I'm usually impressed by the way you are putting information just with 2 words. Thank you. For the history of past medical history, I will start with a glimpse of her past medical history for HBI. This visit is a primary physician visit. It's not an ED visit. And this lady has been dealing with MS for about 3 decades. And she has been through few followers up, and now she's been stable on oclarizumab, which is anti-CD20 antibody, for about 3 years. She's getting the infusion every 6 months, and her most recent one was 2 months ago. About her back pain, she began experiencing back pain a few days ago, and her pain intensified over 2 days ago. The pain is mainly on her left side, and she described the pain as a burning sensation. She rates the intensity of the pain 8 out of 10, and the pain worsens with movement. Her pain does not radiate to any other area. Regarding her weakness, she started to experience some level of a decreased level of energy about 2 months ago, but she attributed her to her MS. However, she's still able to complete her activity of daily living. She's able to walk, she's able to get out of the bed, and she does not use cane or walker. Regarding her past medical history, she endorsed loss of appetite, but she does not have any fever, night sweat, cough, shortness of breath, nausea, vomiting, dysuria frequency, or any abdominal pain. Regarding her past medical history, she has EMS for 30 years. She also has hypertension, hyperlipidemia, diabetes mellitus type 2, and hypothyroidism. Regarding her medication, she's getting alendronate, baclofen, dolutegravir, gabapentin, semaglutide for her diabetes mellitus, simvastatin, levothyroxine, and that oclarizumab, she's getting the infusion. In terms of her family history, there is hypertension and diabetes in her mother and dementia in her father. She does not smoke. She does not drink alcohol or use any illicit drugs. There is no history of traveling, and she lives in Florida, and she does not have any pets. She also does not have, there is no history of allergy to any medication. I will pause here. If you have any question or need any clarification, please let me know.
Thank you so much, Parisa. That was outstanding. It's such a clear picture of what her background is and what context we're dealing with. Austin, what you had that like master schema in terms of weakness. If we were to focus in on that for a second, where are you leaning towards? Do you think this is more neuro or more asthenia or a little bit unsure?
Yeah, no, great question. And I think it's too early to say. I would say it's too early to commit. And to your point earlier, both of these things can coexist. And whenever you hear MS, one of the, and this is in your schema on fatigue, but if you take care of patients with MS, one of the things that is pretty much consistent between any patient is the sense of profound fatigue that is associated with MS as the disease itself. And I feel like I've looked this up before, but I don't believe it's well understood why this is. But the sense of asthenia, it seems to be profound right now, but we don't have anything. What we do have is a sense that the patient seems to have preserved functionality. Like she doesn't use any sort of assistive device to ambulate. That hasn't changed in this acute time course. But as we've seen many times, sometimes weakness can be subtle, and maybe our exam as non-experts, or even as experts, is not sensitive enough to detect that. So I'm in sort of the asthenia space, but understanding that this is a big assumption right now. I think the other thing we have to anchor ourselves in is, we have some sort of acuity to this presentation. And whenever someone has a neurologic disease in which there has been lesions in the brain, we always have to wonder if some of the weakness that they manifest with, even if it's true weakness, is more of a recrudescence of symptoms or signs that have already existed. And so that's another frame that's going to complicate our physical exam when we see the patient. But that's my initial reflections on your question.
Yeah, no, I completely agree with you. I think that we haven't found our pivot point yet. And I think that I don't think we can say that we're starting to gain momentum on where the problem lies. And it's in large part because of the fact that I don't think you can commit either way, though I agree with you. I think the anorexia, the decreased level of energy, and the retained functionality all push us away from neurological disease, but her pre-existing neurological status, I think, tempers that enthusiasm towards that diagnosis. I completely agree. And what do you think about the back pain? What did that do for you?
Yeah, no, I was wondering, Preet, do you have a sense of, if you're willing to share right now, like where on the back it was? Is it in the lumbar spine? Is it in the thoracic spine? Like, where is it exactly?
I personally haven't visited the patient, but I'm telling you from the notes, the pain was on the lower back and on her left side.
Okay, so thank you so much. And then did the patient have any like paresthesias, numbness, tingling?
No, she
Anything that you
doesn't have.
noticed?
She has some She has a weakness on her left side. I will tell you in the physical exam, she's a consequence of her MS, but nothing acute.
Okay, yeah, no, thank you for that information. And, I think
Of course.
going back to the sort of our approach initially of like, are we having red flags or not? One of the things that doesn't fit well into the schema I shared is sort of the location of the pain. I think anytime someone comes in with back pain, we make the leap in our mind that this is low back pain because this is what we see most commonly. But whenever you see pain outside of the low back, that's essentially a red flag itself. The exception being the neck. But if you're anywhere in the thoracic spine, mid spine, like really that should clue you off to say, hey, this is maybe not a typical situation that I'm going to need to anchor myself in. So I'm glad that this seems to be isolated to the low back itself. How to make progress with it? I think we're not getting a particular radicular flare. We're not having associated paresthesias. But again, all of these things are imperfect and insensitive. I've certainly seen many patients in which they describe pain, maybe in their leg and in their back, but they don't occur simultaneously. And the classic sort of dermatomal distribution that we learn about just really doesn't pan out in real life, unfortunately. Again, the description of the pain as burning, certainly in our minds, focuses us in on it being a potential neuropathic type of pain. But again, that descriptor is slightly imperfect as well. It doesn't have enough sensitivity or specificity to say, yes, we're definitely in a neurologic zone. So I think we can say that the patient has low back pain. I think we can say that they have not a lot of associated symptoms to make us think outside of the musculoskeletal apparatus, at least right now. And with a caveat being that this patient has a history of pre-existing neurologic disease in which we could have neurologic manifestations and paresthesias, for example. So I think what might help us make the most progress, or at least make us make some leaps about what the cause might be, is to go back into her history and her, in particular, her medications. So we learned about the anti-CD20 therapy, which is a sort of like, I think of a special version of rituximab for MS is basically what this is. That's how I remember it in my mind. But I think she's been dealing with this for 30 years and, we'll learn more about it, but I imagine this patient has received many rounds of steroids in the past. And this is corroborated by the fact that she's also on alendronate, which potentially is a, treatment for either if she had a fracture or something before, or if she has osteoporosis. Though, this is a bit of a stretch, but she's certainly at high risk for having a compression fracture or fracture of any kind, even from a mechanism that wouldn't necessarily, you would usually associate with a fracture. So that's where my mind is going for the medications itself. The other thing is, she's on multiple medications that could predispose her to having a fall. I think probably she's been on many of these medications for a long time. And we'll have to get a sense from when we examine her if there is a gait component to this that could predispose her to how she arrived at this point right now, but we haven't heard that. I think that's my thoughts here. Rabih, what else do you have to go from here?
Oh, I have nothing to add. I'll just reiterate that the notion that you were introducing, upon which you layered on everything, which is, I think the notion of back pain. You're right that it immediately often makes us think lower back, and then we immediately often to imagine and visualize the musculoskeletal apparatus and the vertebra. And I think that your conversation is just a great reminder that although the vast majority of patients with back pain have lower back pain, although neck pain is an exception, and that most patients with lower back pain have a symptom that ultimately refers back to the vertebra and the adjacent muscles and the discs, like essentially the vertebral column. I think that retroperitoneal diseases can certainly show up as back pain, or primary retroperitoneal diseases like aortic diseases, kidney diseases, or even yesterday's case, a retroperitoneal mass, which Alec and I were reflecting a lot on how there was absolutely no pain involved, which was very, very intriguing. And then you can have primary neurologic causes of back pain. And I think that can be a little confusing because most of the time, the musculoskeletal apparatus, namely the vertebra, the disc, and the adjacent muscles, compress on either the spinal cord or the exiting nerves and cause a secondary neurological syndrome. But you can have primary neurological disease without compression result in back pain. The most morbid example of this is acute spinal cord ischemia. There are so many terrifying case reports, and I've never experienced this, of acute lower back pain being the manifestation of ischemia to the cord. And unlike ischemia to the brain, ischemia to the cord is exquisitely painful as acute coronary syndrome. In fact, there was a really cool case report that I saw on Twitter of somebody coming in with crushing chest pain, and the clot wasn't in the coronaries, it was in the spinal cord. And so that is one example. And of course, there are many other forms of spinal cord diseases that can be painful, including some that are associated with with multiple sclerosis, either directly through transverse myelitis or indirectly through the immunosuppressive effects of the medications causing reactivations of infections. So I think that the comprehensive approach to back pain puts MSK in all caps, but realizes that there are two attachments on either side of MSK. In front of the vertebral column with everything else that's in the retroperitoneum, the kidneys, the aorta, a retroperitoneal mass, or behind the vertebral column with inherent neurological non-compressive disease, of which non-compressive radiculopathy, transverse myelitis, and ischemia to the cord are important considerations. Would these thoughts cross our mind in general? Probably not. But as you alluded to, the burning sensation has a neurological quality to it. Not enough to drop your anchor on it, but enough to wonder, is this a compressive neurological issue, or is this a primary intrinsic neurological flavor to it? Too subtle to latch on, too subtle to lock in on, but enough to latch on to, I would say. All right, Parisa, tell us more.
Thank you. Such a great discussion. In this alicot, I will give you physical exam and initial sets of lab. In her vital sign, she is afebrile, temperature is 36.7. Her heart rate is 98. Her blood pressure is 109/48. Her respiratory rate is 18, and she is saturating 98% on the room temperature. Although she has not mentioned weight loss, she lost almost 5 pounds in compared to her last visit. Her current BMI is 22.9. In her physical exam, she appears ill-appearing, and she is pale. Her sclera is anicteric, and there is no lymphadenopathy, and there is no oral ulceration. Her cardiac exam is normal. There is no murmur. In her lung exam, it's clear to auscultation bilaterally. Her abdomen is soft. No mass or hepatosplenomegaly is appreciated. In her neural exam, she is alert and oriented, and her cranial, motor, and sensory are intact. There is a positive Rumberg test, but exam is negative for ataxia. In her skin exam, exam is notable for non-palpable petechium purpura on her lower extremity bilaterally. In her musculoskeletal exam, she has normal tone in all her extremities, but her strength on her right arm and right leg decreased to 4 out of 5. Her left arm and left leg have a normal strength. She's mentioning that she has this weakness since years ago, and it is a chronic presentation for her. In terms of her, I had the plan to also give you initial lab. If you would like, I could pause here, or do you want me to continue?
That's a master presenter. I think you're realizing that the exam is really juicy itself, as Francisco just said in the chat. Yeah, I think maybe we can try to guess what the labs may be. Parisa, is that okay with you?
Yes, of course.
Okay. All right, Austin, what are you thinking?
Yes, so what a Parisa case here, just sort of pulling the rug out from under us. And, I'll try to tackle things systematically here and have Rabih lay over his wonderful reflections. But I think, looking at the vital signs first, the heart rate of 98 is maybe a signal that to suggest that maybe this person is a little bit stressed. And the blood pressure, she's a young, older woman with normal or even slightly low BMI. So I think it's hard to make exact progress with that. And then the pulse pressure is slightly wide, but it would be nice to know what her prior readings are. And there's a lot that goes into measuring blood pressure and making sure it's accurate. So it's hard to know how much diagnostic progress to make on that. But I think if we took the vitals of a patient that we were seeing in the clinic or the hospital even, and didn't know anything about the patient, and we looked at them, I would say, not too bad. I could probably wait a little bit of time to see this patient. But then the general appearance, like this patient looks pale, they look unwell. I think that just speaks to the power of the general appearance in the physical exam. Like you could have normal vital signs. You can go look at a patient and say, my gosh, this person worries me. This person scares me. I think this is a great example of that. And then later down, as we started looking from head all the way to the toes, we eventually found something that we could anchor on a little bit. But that's my general sense to start off. Then we get through the head and neck exam, the lungs, the abdomen, and didn't really find too much. As far as the extremities, we have the surprise here for us of this with non-palpable purpura, petechiae. And, I think we're always in a place in these exercises where we say, hey, we're going to try to link this together. This could be a pivot point. But in real life, maybe it's not. And so I always try to step back and say, hey, can I link these two things together? And certainly things come to mind. But I think it's always important to step back and be like, okay, if I go back in the chart and search lower extremity edema or search petechiae or lower extremity rash, like, is there a signal there? And I've certainly been humbled by that before. It's like, oh, I have this thing going on. I need to work the patient up. And then I go back in the chart after the visit and so they've been to the dermatologist 7 times for this condition over the last 20 years. So it's like always humbling. But in this particular case, when we're seeing the combination of a neurological flare of symptoms plus these palpable purpura, I think we're in the space of vasculitis, and that's where we're worried and concerned about right now. But we also want to start to get some other evidence to corroborate with us. And one of the things we were worried about initially when the patient came in was, is there focal neurologic signs? And I think the only things we really found were a positive Romberg, and the fact that this patient has 4 out of 5 weakness in the right upper and right lower extremity. This is tempered by the fact that, the patient has pre-existing MS and she's saying, hey, this is my baseline. But I think careful examination by someone that had seen her previously or a review of the notes to really say, hey, this is truly something that has been the same, exactly the same. It's always been 4 out of 5 in our documented exams. It can be really, really helpful because sometimes patients are so good at compensating or so good at going through life that even subtle differences that might be signaled to us, they might not appreciate themselves. And I had a patient like that yesterday in clinic, in fact. So that's, I'm sort of keeping that in the back of my mind. The positive Romberg test, I think in the Academy chat, I asked how people perform the Romberg test, and everyone said they did it slightly differently. But I think, we always typically, the sort of bad way they were taught in med school is Romberg is cerebellar signs, which it is not a cerebellar sign. It is a sensory ataxia sign. But even then, the sensory issue that's wrong is slightly nuanced. Sometimes it can be the dorsal columns. I think that's the one that we think about the most. And then the peripheral nerves, the sort of large fiber or myelinated nerves being a problem. But another thing that can cause a positive Romberg is a more vestibular issue. And so sometimes we use the terminology of Romberg and it's positive, but the way we perform the exam and how we interpret the test can be much more subtle and much more nuanced. So right now, if I had to step back and say, what do I make of a positive Romberg? I'm actually maybe not putting too much stock into it right now. But if I try to loop together, like, okay, she's a positive Romberg, she has palpable purpura, she has a neurologic syndrome. Is this signal for neuropathy we haven't discovered until this moment in time? And when we walk the patient, I'm sorry if I missed the gait exam. Maybe this person has a wide-based gait or a sensory ataxia that we didn't appreciate before. So long story short, because I've been rambling on, I think the exam I'm not too struck by from a neurologic standpoint, but from a skin standpoint, I'm definitely struck by it. And I think as Rabih has a nice approach to the rash, how wide, how deep, and how progressively it happens. So if we get the time course of her presentation for the rash is the same as the back pain and the weakness, plus the depth of the appearance of the lesions, I think we're worried that there's a systemic process and we need to go diving a little bit further. What do you think, Rabih?
Oh my gosh, I love how you took the time to explain why you weren't using the Romberg in your analysis. That's just a marker of the teacher that you are. I didn't jump in to tell you that the purpura Parisa said was non-palpable, in large part because I wanted you to share that teaching and to see what connection you would make, but also then to like reflect on what you might do and update your thinking when you learn it's non-palpable. What does that do for you?
Well, thank you so much.
I could
I'm
have
sorry
corrected you
that
earlier, but
I
then people would have
expounded.
gotten
Yeah,
all that teaching.
I expounded far too long. So non-palpable purpura.
Yeah.
Okay. So again, I guess if we step back and say what causes petechia and purpura in particular, it's like there's some sort of the blood vessels are leaking and there's blood that is entering the skin. And how the mechanism of how that's happening, you can sort of make progress if it's palpable or non-palpable. When it's non-palpable, it makes me think that this is usually more of a non-inflammatory process. So we have a vasculopathy, so a vessel issue that's probably non-inflammatory, or we have an issue in the blood and the coagulation itself, in which is just the contents there are leaking out and they can't stay in for whatever reason. And so I think our CBC that we will hopefully be receiving next will help us make progress, and maybe if it doesn't, then diving into the coagulation cascade a bit more might be helpful. But those are my thoughts too.
There, I love it. We got the teaching for non-palpable, palpable, and then the teaching for palpable. I completely agree with you. I think that it's amazing how you can try to work on predicting a CBC based on exam, and then when you see non-palpable purpura in the combination with pallor, I think that the probability of concomitant anemia and thrombocytopenia is reasonable enough to start to think ahead. So if you're in this moment, you're going to get a CBC back bare minimum in 40 minutes. So the question is, if you have a pretest probability of low platelets and low hemoglobin right now, what should you do differently? And I think for sure you should get a type and screen in case you need to transfuse this patient and start to think about, well, okay, what causes anemia and thrombocytopenia? But as soon as you start to do that, you should stop, because we don't know if we're actually going to be dealing with a bicytopenia or a pancytopenia. And the approach to those things is so different. So I would say from the get-go, I'd be getting a type and screen in this patient. And hopefully we're wrong. And hopefully this is just trauma on her legs because she's falling or stumbling. But open to the possibility of anemia and of bicytopenia, maybe even pancytopenia, which then puts the back pain in a completely different light. Because if you're thinking about a patient who's thrombocytopenic who has back pain, it's a retroperitoneal or even worse, an epidural hematoma until proven otherwise. And if you're thinking about a hematological syndrome and back pain, in addition to the consequence of low platelets causing bleeding, you have to think, is there bone marrow expansion in the spinal cord? And does she have bony disease causing her pain? So the hematological imprint will have to hold on to because it's so powerful, but not to forget to take it back to what the patient came in for and connect that with the back pain. Or at least try to connect it, but be open to the possibility it's true and unrelated. All right, Parisa, tell us more. And thank you for choosing to pause here. I think it was well worth it.
Of course, such a great discussion. About Austin's question, I found notes for positive Romberg test since few years ago, maybe 5 years ago also, but I didn't check the blood pressure, unfortunately. But the skin findings are recently developed. This is a new visit. In terms of initial lab data, I'm giving the CBC first. Her white BC is 1.4, absolute neutrophil count 240, hemoglobin is 7, MCV 121, and platelet 29,000. I'm giving you also the baseline for 2 months ago, which white BC was 3.7, hemoglobin 12.1, platelet 310,000. Her UA is normal, and in her initial chemistry, sodium is 140, potassium 3.8, color 100, BUN 12, creatinine 0.7, glucose 103, calcium 9.5. Has PTT slightly decreased to 22.3. The normal range is between 23 till 32. His PT is normal 10. INR is normal 1. Her liver profile were normal, AST 19, ALT 16, and alkaline phosphatase also normal 74. Her albumin is 3.9, and her total protein is 6.6. I will pause here. Thank you.
Oh my gosh. Oh wow. That hematological fingerprint is certainly very strong. Yeah, how are you coding that hematological fingerprint, Austin? What are you representing that as?
Yeah, right now, as you were mentioning, we're sort of in the space of we were deciding how many cytopenias we had, and I think we have pancytopenia. So we're in the space of pancytopenia, and I think we're going to have to solve that problem and layer in the context of the patient's background and their presentation to this point to try to make progress in that way. But I think while I think this finding is interesting in the sense that I think this helps us make diagnostic progress because we have a pivot point, but simultaneously the potential possibilities of what could happen have expanded significantly, at least in my mind, at least in part. And I think in one way, the leukopenia, in particular neutropenia with the absolute neutrophil count of 240 is so profound that the possibility of infection and atypical presentation of infection has really gone up. We already knew that the patient was relatively immunosuppressed with having MS and then being on the regimen that she was. But I think the profound nature of this would make me, at first pass when managing the patient, wonder if, even without other systemic symptoms, wonder if we need to be treating this patient for an infection or depending on how long our investigation would happen. But I think if we layer in pancytopenia with everything going on, my approach to pancytopenia for anyone that subscribes to RLCP servers, which everyone should, but they have a recent case where they discussed pancytopenia, and there's like 4 different schemas that they have for pancytopenia. And I reviewed them last night, actually, when I was in bed, but sadly, I can't remember any of them. So I'll go through the one that I tend to remember best. And this is just me that I have a trouble with attention, so I just have to do things over and over and over again. But my approach to pancytopenia is really, do we have a periphery problem? In particular, destruction from an antibody-mediated process. Do we have some sort of issue with the spleen, which could be any type that would cause splenomegaly, that could cause sequestration? And then lastly, we got issues within the marrow. And then when we can break down the marrow issues into really a few different buckets. So one being a stem cell issue. So we have a primary issue with the stem cell, like a hematologic malignancy that we would be worried about, like a leukemia, for example. Do we have an issue with destruction of the cells, like coming out of the marrow, and there oftentimes that could be like a nutrient, there could be an autoimmune issue, but usually there'd be like a nutrient related or environment related issue, in particular like vitamins that we would think about. And then is there something in the marrow itself that's getting stuck there, that's pushing all the normal good things that are supposed to be in there out? So is there infection? Is there cancer? That kind of stuff. So how do we make progress within that here? I would say, I think the MCV is particularly interesting because I know it'd be interesting to know. I didn't catch, Parisa, do we have an MCV from the prior CBC?
No, I couldn't find it, unfortunately. Sorry.
All right. Oh, no worries at all. And so I think we have to make the assumption that this is new just because of the patient's presentation and the profoundness of the pancytopenia. But whenever I see an MCV of 120, I think the first thing that should come to mind is this patient has and we'll need a smear to corroborate this, and that'll be an important test that we get. But this patient has a megaloblastic anemia and has, potentially B12 deficiency, and that could manifest with a pretty profound macrocytic anemia and pancytopenia. I think that would be one option. The other thing here, though, in someone who is older and has a level of immunosuppression, would be to wonder if this person has MDS or another type of hematologic malignancy that would make us wonder, to make us very concerned about this presentation in particular. That's my initial reflections on the CBC. The remainder of the labs, I think it was very nice for us. There wasn't any other hematologic signature seemingly as far as the coagulation cascade. So I think we're anchoring that the purpura are probably related to the thrombocytopenia itself. And then the liver tests are particularly striking in the sense of not so much that we were worried about the liver, but are we getting signals for hemolysis here? And at least between the AST, the bilirubin, We're not seeing that right now, though I would still probably send the remainder of the test just to see if we can make progress, because, also on the differential with the macrocytosis, though usually not this profound, at least in my experience, would be some sort of warm autoimmune hemolytic, or just any sort of autoimmune hemolytic anemia. Yes, I think, I've gone on a ramble, so I think maybe Rabih can chime in to sort of reframe me, and we can go from there.
No, I completely agree with you. I love how the order in which you analyze that. I think that's very telling. I mean, you first shared your approach to pancytopenia and then used the MCV as a clue, and to recognize that the weight of the MCV is strong, but it's not definitive. And I think you'd be very, very happy with an explanation for the pancytopenia. And maybe if the MCV is just a fake out or a distractor, I don't think you would spend too much time agonizing about that, as long as you've learned that the patient had a good answer for the pancytopenia. So if you found out the patient had acute leukemia, you'd probably be like, well, I don't really know how that can cause a high MCV confidently, but I'm happy that I'm happy with that as an explanation. And so starting from there, I think that that's where the RLR schema comes in for the 4 S's of pancytopenia. Is, are you dealing with a substance, a stem cell issue, a systemic disease, or a space occupying process? And though those are actually very, very complicated to explain in more detail now, but those are the 4 S's we use. And I'll reiterate Austin's plug to subscribe to RLR for more details on that. But I think the ones in which the center of gravity or the whole conversation or most of the conversation is around the pancytopenia, it's often because of a sneaky substance that goes and affects the bone marrow or a stem cell issue. And so to take a moment to expand on substances, it can be substances that are present in excess, like medications that suppress the bone marrow, like methotrexate, or toxins in excess, like alcohol. And here, as we scan the med list and the toxin list, I don't think there's a strong hit that I'm aware of, but my major gap in knowledge is the anti-CD20 antibody that she has. I don't know anything about that, really. So that's the substance category in excess. The substances can also be deficient, and that's where you said B12 really, really is important. Stem cell issues, I think it's really, really important anytime you get pancytopenia, especially when the conversation is all about the marrow, to wonder, could this person have a stem cell issue in the form of leukemia or aplastic anemia? And I think in the context of the back pain this person's having, I'd really worry about the possibility of leukemic marrow expansion. It could be on the backdrop of MDS, or it could be independent of MDS. And so let's hope it's B12 deficiency, but I think we probably should prepare for the possibility it's not. A very helpful test that you can get from the get-go is an LDH. And LDH is often through the roof in B12 deficiency for fun reasons we can speculate on later. But yeah, I completely agree with your analysis, Austin. Start with pancytopenia, subscribe to RLR for the 4 S's. The 4 of them are substance, stem cell, systemic disease, and space occupying process. If you're trying to figure out where to start, if the conversation is centered around the marrow and there are less extramarrow symptoms, it's often a sneaky substance or a stem cell issue. And the sneaky substances on the hook are B12, and the stem cell disease I would worry about the most is acute leukemia, especially in a patient with back pain. Alrighty, Parisa, tell us more, please.
It was a fortunate coincidence that the 4S nominee came out yesterday. I prepared this case last month. It is just. I will start with retic percentage, which is 5.7. Her LDH is high, which is 323. Haptoglobin is normal, which is 70. In terms of second S and nutritional study, B12 is 1,980, which is high. The upper limit is 1,245. Methylmalonic acid is normal. Her iron level is normal, TIBC normal, iron saturation normal, 30%. His ferritin is high, 324, and the upper limit is 150. In infectious study, in terms of tick bite, PCR for anaplasma and Ehrlichia are negative. Lyme antibody is negative. Babesia, IgM, IgG negative. EBV, CMV negative. 3 H's are also negative: HIV, HPV, HCV. I also have some imaging. Do you want me to give it to you now, or? Her abdomen ultrasonography shows normal spleen and liver with normal echogenicity. And her echocardiography is also normal, no vegetation, normal ejection fraction. This patient got admitted because of her wide PC, and during the course of hospitalization, she also developed some shingles rash on her back. I will not give you the PBS now. It is for the next ALICOT, which is revealing the final diagnosis.
Austin, thank you, Parisa. That was so helpful. A lot of really important data. Where is your head out now, Austin?
Yeah, man, such a juicy case. Thanks so much, Parisa. And I think the labs are particularly interesting for a few reasons. So the reticulocyte percentage at 5.7%, I think suggests that I didn't do the calculation, to be honest, but I'm getting the sense that probably her marrow seems to be responding. And so if that is the case, then I think that sort of puts ourselves more into, is there some sort of actually, now that I reflect on that, we were talking about before, like, is there a substance issue? Is there a stem cell issue? And if there's a stem cell issue, you're not going to make stem cells. You shouldn't have much of a reticulocyte response potentially. And then if someone is having a substance issue where they cannot make things within the marrow itself, then you would also expect a low reticulocyte count. So I guess I'm a little bit perplexed by that. I like that we went down it started to explore the environmental route a little bit with the B12. And, I think a high B12 always, I think our first reflex thought is like, oh, high B12 cannot be B12 deficiency. And I think that's where an error is often made. And one of the interesting things, and I encountered this in clinic recently, it's like, oh, how the patient has a high B12. How could they have high B12? They don't take any vitamins, they do anything like that. And so one of the sneaky things that can cause high B12, I think most commonly what I've seen is patients who have cirrhosis or liver, or particular advanced liver or kidney disease. That's a way you can get sort of like a false positive B12. But the other one that we're particularly worried about here is primary hematologic malignancies. That's the one where you sort of a false positive B12. Without expounding on that too much, the issue is that almost certainly if this person had such profound B12 deficiency to cause pancytopenia, macrocytosis, the MMA would be high. The MMA is an imperfect test, but the way it's imperfect in patients that older is often falsely elevated. So the fact that it's normal here, I think strongly argues against that this patient has B12 deficiency. But that was an interesting point to reflect on. I think the other thing here is we have this LDH. It is high. I'm not exactly sure how excited I am about it from a hematologic standpoint. I think we know that there's something going on in her back that we have yet to figure out substantially. So maybe she has a lesion there that is causing a little bit of cell death, and that maybe explains why the LDH is slightly elevated. But it's an important measure for us to track. I think it helps maybe support our hypothesis that this person has a hematologic malignancy, but I'm not sure it's profoundly abnormal enough for me to make significant diagnostic progress with it. And then the other findings, we don't seem to have any other evidence of hemolysis, which is helpful. I think the other thing is, the iron study is normal and the ferritin is, and a lot of these findings are just suggested or support that this patient is inflamed. And so how the team was making progress on what is the nature of this inflammation. I guess in first pass, I have to say, I wasn't necessarily thinking about checking for tick-borne illness or viral infections. And I think that speaks to, is there something suppressing the marrow that we're worried about, as Rabih mentioned before. But I have to say I didn't exactly understand the thought process of that. So maybe Rabih can expound on that. Maybe I'm missing a connection that I need to be making. The other thing is, I think I can understand the abdominal imaging just from is there splenomegaly? Because I think that would potentially change our approach to this case for sure. And then what I do remember from that 4S schema, to redeem myself, because otherwise Rabih and Reza are going to just sort of ban me from the website, was about, is this image positive or image negative? And so we seem to be in the image negative space, and that might help us make progress as well. And then the echo, again, I think they're trying to get at, does this patient have endocarditis? And there's some sort of, this is a subacute endocarditis, we're having an inflammatory syndrome that can be suggestive of that. But I'm also not exactly understanding the rationale for getting the TTE unless this was like palpable purpura or something like that. So those are some knowledge gaps that maybe Rabih can fill in for me.
I don't know if I have anything to fill, my friend. Just for the sake of time, I'll kind of summarize our progress in the 4S schema. So is this a substance? We don't have any medications that I know of, and I think as you expertly alluded to, B12 deficiency is unlikely with that MMA being normal. Is this a space-occupying disease process? I think that we haven't found anything that's occupying any space, and so that's less likely. Is this a systemic disease? I think that's where the two systemic diseases really that deserve specific attention are tick-borne illnesses, which have been thoroughly evaluated for and excluded. Although admittedly, the pretest probability of them was fairly low given the lack of overt symptoms, but the patient is immunosuppressed. So I can understand why you might use that as a reason to pursue testing for them. The other big systemic disease is lupus, which is important to think about in anyone with any autoimmune disease history, maybe particularly with drug-induced autoimmunity. And so an ANA might be helpful here. But when you're invoking lupus in an older person, I think that pretest probability should always be low. So with the only real workup that might be considered as an ANA left, I think the case for a stem cell issue is getting hotter and hotter and hotter and hotter. And the question is, how do we reconcile that with a retic percentage? And the answer is, I'm not sure. I really don't. I'm excited to reflect on that when we're done. But I think, yeah, we'll see where the next tests, I think, are to look at the red blood cells and the platelets on the peripheral smear and maybe eventually get a bone marrow. Alrighty, I'll pass the mic to you, Parisa, to tell us the next aliquot.
Exactly, you predict the next aliquot. The PBS is showing pancytopenia with macrocytic normochromic anemia. There is no evidence of schistocytes or hemolysis or microangiopathic process, but there are rare blasts in the periphery. Considering the high such features, the patient undergone bone marrow core biopsy, which is showing markedly hypercellular marrow, 90%. The blast increased to 17. Myeloid element exhibit limited maturation, and immunostains showed CD64 blast comprised of 25% of total cellularity. Fish were also positive for deletion of chromosome 5 and rearrangement of KMT2A and TP53 mutation. It was a great discussion by you. I am really grateful. The main reason I bring this case, it was a PROFRES leukemia illness script, and specifically the patient has less than 20% blast, but because of the specific mutation, there are categorized in AML. And specifically for this patient, she has complex karyotype, and she is diagnosed with therapy-related myeloid neoplasm. Because in her MS treatment, she was treated with mitoxantrone on 2000. At the time, this medication was disease-modifying drug for MS. It was FDA approved, but unfortunately, it is a topoisomerase 2 inhibitor, which might lead to this kind of long-term consequences.
Oh my gosh, Parisa, I'm so grateful. Every single case that you brought to us has been so full of learning. And I'm really glad that we got to a diagnosis of leukemia, but got to reflect on very important bread and butter things like fatigue, neuro versus asthenia, and all the things that Austin got to teach us about. Austin, what are you thinking? What are your takeaways from this case?
Yeah, wow, thank you so much, Parisa. What a wonderful case, a wonderful journey. My takeaways are, I had sort of made the inference on her medications at the beginning about, we learned about the ocrelizumab, and I mentioned the possibility of steroids and looping that in to the pain that she had. But I think I could have taken that a step further and said, wow, she's had 30 years of treatment, and the treatment for MS has dramatically changed in the last 30 years. Even in the last 5 years, it's changed significantly. So I think that was maybe another step that I could have taken to talk about this patient exposure. I guess, Parisa, what was the explanation for why the patient had back pain in the first place? I think, was it the thought that they had marrow expansion and it was just like particularly focal in that area to cause symptoms? I mean, I was reflecting on yesterday's case again about bone pain and, why some patients have bone pain and why some don't. And the answer is incredibly complex. and I couldn't make too much progress. But what was the thought of why the patient had pain?
I think because she developed shingles rash when she hospitalized.
Oh
It
my
was
gosh,
the
I totally forgot
prodrome
about this.
presentation.
Yes, I totally forgot about the shingles. Oh, thank you so much. Yeah,
Of
no,
course.
that makes perfect sense. Yeah, no, wonderful case, wonderful journey, and thank you so much.
I couldn't. I love. By the way, sorry, I got a phone call from work. I love that you went back to the chief complaint. I think that's so telling, and ultimately we have to link it together. And I think you're seeing the manifestation of leukemia in the back is usually marrow expansion, but here it could have been that too. But another yet sneaky manifestation of leukemia is its immunosuppressive effects. And I think the burning sensation and the lateralization of the pain is much more evocative of zoster. I'm really, really sorry that I have to step out now to make it to work on time, but thank you, Parisa. This was a really, really educational case. Austin, a real pleasure and a treat to co-discuss with you. And thank you for plugging RLR. I will tell Reza that we use his teaching deeply today. And we'll pass the mic to Kushal for the teaching points. Austin, I'll make you the host. Do you have time to stick around for the teaching points, Austin? Cool. Okay, I'll make you the
Hello.
Oh yeah, Kuchal, whenever you're ready.
Hey, hi, can you all hear me? I was just like suddenly just great. So it's amazing case. Thanks a lot, Marissa, for presenting it. And Austin, you did a great job discussing as usual. And so my three takeaway was one, to when a patient comes with back pain and weakness, to see if they walk by themselves or if they were brought by an ambulance. And the second one was to see it in relation, whether there's a time course, red flags, whether they are present in the past history, because then they would help us to narrow down the diagnosis. And the third one was also if the patient is having a profound pancytopenia, to look out whether it's the reticulocyte count, to see if it's either due to substance infiltrating the marrow or due to substance abuse itself or due to stem cell issue or if it's due to systemic disease. And the fourth one was also to look at the marrow, the macrocyte MCV levels to see if it's related with macrocytosis. And the last but not the least is the Romberg sign is to do with the sensory ataxia and not the cerebral symptom.
All right. No, thank you so much for those rapid fire teaching points and a great summary of the key takeaways, because I definitely rambled on for long periods of time. So thanks so much, everyone, for coming. It was great. It was a great another VMR, and we hope to see you again tomorrow or sometime in the future. Bye-bye.